Good morning, and thank you for joining us for this nicer education session. Today's session will focus on genetic testing results, communication and comprehension in conveying those results. The session will run as follows. We'll have 2 talks, and then a brief break, a third talk, another break, and then a live question and answer session. Feel free to ask any questions into the Q&A tab throughout any of these talks. And without further ado, I'd like to introduce our first speaker, Dr. Xiao Peng. Dr. Peng is Assistant Professor of Pediatrics and Genetics at Montefiore Medical Center and Albert Einstein College of Medicine, respectively. She completed her bachelor's at Caltech and graduated from the Cornell Rockefeller Sloan Kettering MD PhD program before completing residency at Johns Hopkins University. She is director of the Advanced Diagnostics and Therapeutics program for the New York Center for Rare Diseases, as well as director of the Genetics of Blood and Immunity Service. She is the current research chair and Unhide program co-chair for our very own NICER consortium. And now, her talk.
Hi folks, I'm Dr. Peng, and I am the director of the Genetics of Blood and Immunity Service at Montefiore Einstein, and I also run the Advanced Diagnostics program for the New York Center for Rare Disease. And it's my privilege to be able to talk to you guys today about how to sort of think in a very foundational and common sense manner about formulating molecular diagnostic testing strategies. Because this is something that many people are finding themselves having to deal with more and more in their practice. So first I want to just step back and get some perspective on where we are in medicine and why we're doing so much of these molecular kinds of diagnostic tests. Certainly in the past, we had a lot of kinds of assays where really they enabled us to describe certain patients' clinical presentations better, but they didn't really allow us to look under the hood to see maybe what was driving those presentations. We're very lucky these days to have a lot more assays of the second type, whether it's molecular genetic testing or cellular and biochemical testing. They enable us to characterize human disease on a deeper level to get at the pathophysiology of the disease rather than just a more granular surface description. The challenge here, however, is how to reconcile all these different layers and these different kinds of assay data so that we can sort of formulate both a clinical diagnosis and molecular diagnosis for our patients. Really, in the pre-molecular era, if you think about what geneticists were doing as clinicians, it's really very much like art historians. So we basically were comparing what our patients' features were that we were able to look at or measure with the available tools and saying, oh, okay, well, if they have these features, maybe it's Holt-Oram syndrome, and if these other features, then maybe it's more likely to be Down syndrome. Similarly, with art historians, they were looking at paintings and saying, okay, well, if the fingers look like this and the line looks like this and the colors look like that, it's maybe more likely a Mantegna, and if it's this other way, maybe it's more likely a Bellini. Now, if you think about how many misattributed two-dimensional paintings there are in museums, you could probably figure out that that was not easy to do, and certainly it's more complicated when you're dealing with how dynamic something like human biology is. So really, we've been very lucky to have some additional tools that can help us do that kind of diagnosis in a slightly more objective way. And really, it's only been in the last decade or so that we've had the ability to do clinical grade genetic testing. And that means that now you're able to basically hand in your patient's DNA sample and then a few weeks later get a result that enables you immediately to sort of inform your patient care decisions and your family care decisions. This is pretty amazing if you think about it, because it wasn't until 20 years ago that we even knew anything about the human genome. We didn't know where the genes were, we didn't know what the genes were, we didn't know where they were in relation to each other. We certainly didn't know what they do, and we still actually don't know what most of the genes that we've identified do. But now we've certainly come to a point where people are sending a lot more clinical grade genetic testing, and sometimes very large amounts of genetic testing and very big kinds of tests that enable us to sort of have an additional piece of data that can really inform patient care from the why perspective. Having this luxury means A, we're still on the steep end of the learning curve, but B, it's enabled us to make some advances in terms of how we think about human disease and certainly how we think about genetically driven disease. So it's contributed to the expansion of our understanding of the full clinical spectrum of known monogenic disorders. It's expanded our genetic landscape of clinical phenotypes that we know of, so that we're starting to be able to say more and more, even for common diseases, whether or not there might be monogenic underpinnings that are part of the architecture. We can manage our patients better because we have this combined power of genotype phenotype information. And another thing we don't talk about enough, which has been really, really powerful, is the fact that because we're able to identify patients with rare monogenic etiologies of disease, it's also helped us better understand how we can take care of those patients who may not have that, but have similar presentations that are maybe a different genetic architecture and maybe more presumed to be polygenic. This is a lot, right? So how when you're faced with a patient sitting in front of you, do you even begin to think about diagnostic testing strategy from a molecular perspective? Well, what geneticists do is basically summarized on this slide. And this is something that we can sort of try to teach everyone how to do. And it's probably something you're already doing without realizing it. So you're basically taking what you know about your disease, you're taking what you know about the clinical paradigms that suggest whether you're barking up one particular mechanistic tree or another, you're putting those together with the genetic paradigms you know about for your differential, and then you're combining that with your understanding of the available molecular assays and analytical tools to say, well, this is probably the best kind of test and the best kind of analysis for this question where I'm trying to identify lesions in these kinds of genes because I think these are the genes that cause that disease. And you're using that both to formulate your diagnostic strategy, but sometimes simultaneously you're thinking, oh, well, because it's this pathophysiology, I think I might want to manage the patient in this way. So it's almost like you're thinking about both of these things in parallel. So I just want to use a quick example since I work with genetically driven blood and immune disease. My conceptual framework when I see a patient for the first time in clinic is to ask about different facets of immuno-heme disease, which I sort of laid out in very sort of basic ways using this kind of map. Now, this is very simplistic, and actually a lot of where I've mapped these processes, it's probably not even accurate, but I just want to give you a sense of like how we think about these, which is if the person has maybe a higher dominant kind of immunodeficiency phenotype, we maybe think of some pathways versus if the patient has maybe a more systemic autoinflammatory dominant phenotype, we maybe think about the involvement or the impairment of other pathways. And so we kind of use their clinical presentation to help us identify and match appropriate pathobiologies and triage those on our list. We're not really just trying to match symptoms because symptoms can mislead us a lot of times. And they may not always hint at the primary driver of the disease, which is what we're really trying to get at when we're trying to get our patient to a genetic diagnosis. So then we take that, and I'm going to use the example of cytopenias as sort of my example because it's something that we see so frequently in our clinics. So how many times do you get a cytopenia referral? And you're starting with I'm not even sure it's immune mediated. I don't know if this is primarily hematopoietic. I don't know if it's something else, right? So you're sitting there thinking, okay, there's a lot of roads that can lead to the outcome of cytopenias. Which of these kinds of mechanistic buckets is my patient more likely to fit into and which one's not, okay? And if you think about the diversity of mechanisms, you quickly realize that it may not be enough to send a gene panel, right? Because the gene panel might be designed for cytopenias and bone marrow failure, which is primary disorders of hematopoiesis, and you may not yet have the data for that. If you do have the data for that, that's great. Then you might say, okay, I'm really, really sure that this is not immune mediated. I'm really, really sure that this person does not have a metabolic problem. I'm really sure this person doesn't have a liver disease problem or some other organ that's affecting the situation. Then, okay, yes, like your primary suspicion can be limited to that much smaller group of genes, and you might choose to send more specific testing. But a lot of situations, there's multiple possibilities. Even, for example, in patients where we know that there's bone marrow failure, we can't always say that it's necessarily not immune-mediated because, for example, patients with Fanconi anemia, they can have both problems. They can have primary hematopoietic problems and immune-mediated cytopenias, right? So then you might be sitting there thinking, okay, I really am not confident that this could not look like an inborn error of metabolism causing this, or I am not confident that this can't be a primary immune disease. So maybe we need to do bigger testing. Maybe we need to include all of these different buckets of mechanistic possibilities. So this is something that is really, really important to consider when you're strategizing about genetic testing, which is basically what is the size of the genetic landscape you think you need to accommodate, because that'll be one of the features that goes into how you pick your test. Just showing here, like we use a lot of non-genetic testing that is very valuable to help us refine our differential. So if you have functional data that says, oh wow, my patient has a defective form of fast-mediated apoptosis, so maybe the reason they're having immune cytopenias is because you're suspecting that they have primary ALPS, even if they don't have obvious autoimmune lymphoproliferative syndrome. Maybe you got a DEB assay and it says that they definitely have increased chromosomal breakage. Well, then you probably don't need any of these other genes to be looked at. You just need to get a panel for Fanconi anemia, right? So all of these are really, really important to use as well, because relying on genetic testing alone, as we'll talk about, really is a garbage in, garbage out proposition if you don't know what you're looking for and if you're not getting testing based on accurate phenotyping. It's also important to just be careful about interpreting assays, even though some of the assays you might be using are really, really good assays, because over time they evolve their associations. So in the past, we always used to say that certain things like IL-10 elevation, vitamin B12 elevation, combined with expansion of TCR alpha beta double negative T cell subsets was very specific to the fast-mediated apoptosis pathway type of genetic ALPS. The problem is, over time, we've also discovered there's a lot of other ALPS-like diseases that can also lead to these exact same features. So as more data accumulates about disease, we need to be careful not to continue to make the same assumptions that are the disease-specific studies we thought were specific are still specific. Another really important thing to be conscious of is the fact that we probably don't know enough about the immunoheme presentations of a lot of genetic syndromes, and we really need to distinguish between what's truly absent from those syndromes and what might have just been under-examined when we think about the potential differential. So I'm going to talk a little bit now about the kinds of tests and how we think about using those and how we choose those. One thing that's really important to remember is that you're going to follow your patient for a very long time. You're going to be their provider through their disease course, okay? So it's not a one and done deal. It's always important to go back and reassess them, and don't get discouraged if you don't get a molecular diagnosis on the first try. We very rarely do, okay? And it's always important to go back to drawing board and continue to reevaluate them and to rethink your assumptions. So the first kinds of genetic tests that existed were based on Sanger sequencing or PCR strategies or other kinds of earlier developed assays. And those are still very useful in a lot of circumstances, okay? So don't knock them. There are lots of situations where you may only need one of those for a specific locus or a specific gene. These days, you probably see this kind of platform the most, the massively parallel, or what some people call next generation sequencing based on short read, mostly Illumina platforms. This is really the basis for most of the clinical grade assays you might encounter that are gene panels, exomes, or genomes. And then, of course, there is third generation sequencing. There is true single molecule sequencing, or what people might call long read sequencing. There's also other strategies like optical genome mapping that are currently being developed for clinical use or are emerging into clinical use, but are still largely on the research side available right now. One of the things you'll probably hear about or see a lot is this idea that a gene panel is a slice of an exome and the exome is a proportion of the quote-unquote whole genome. So that's kind of true, but it's important to remember that really, even with the genome, we're not assessing the whole genome. We can't actually use short read to cover a lot of parts of the entire genome. But certainly the great thing about whole genome is that it enables us to have a lot of non-coding space disease discovery where we can pick up those variants, but we actually don't really know what to do with them a lot of times. And this is like going to be one of the major advances we hope will happen in the future, is knowing how to use all of that non-coding data. The exome currently is only about 1.5% of the entire human genome, but it encompasses 85 to 90% of the known variants associated with disease. And so you could probably figure out that that's a good amount of ascertainment bias because we know what to do with those variants for the most part that are found in coding space. And we're probably missing a lot of other things we don't know how to analyze because we don't know what they do. And then certainly the thing about gene panels that's important to remember is they're very highly variable in the way in which they might offer detection and gene content. So you have to be really careful not to assume that they're all exactly the same. Really, really read the fine print. I'll talk a little bit more about that later with an example. So the next step in choosing genetic testing strategy, once you sort of have a good idea about what your differential is, of course, is to then understand what are the pitfalls of that differential. So do you have genes that require some very special kinds of testing? Do you have genes that are particularly annoying to try to detect using the available strategies? So this is where you then take the genes on your differential and think about all of these features that they might harbor and how you might run into problems or not with the kinds of assays available to you to pick the best one. That can't happen in a vacuum because you're dealing with a real living human being who is in a hospital somewhere or in a clinic somewhere. So we also cannot escape the logistical reality of the situation, which is what is the context, what are the institutional rules, what are the rules for the performing labs available to you, what are the questions that you're trying to ask, and then really, really importantly, and this is something I want to take some time to emphasize, these three features must be fulfilled if you're going to pick an appropriate genetic test, okay? We don't talk enough about this for any assay, but we need to think when we choose assays whether or not they're analytically valid, which is, can the test you picked actually pick up what you intended to detect? Is it clinically valid? Is the test the right one for your clinical question? And is it clinically useful? Why are you doing this if you can't get medically actionable results potentially at the end of it, right? And this happens all the time where we maybe are picking a test where the test itself actually can't detect some of the things we need it to. And so we get what we think is a lack of a diagnosis because the patient doesn't have the problem, but really we picked the wrong test. Sometimes we pick a test maybe where not all the genes we needed that were relevant to the clinical question are actually on that particular test. So then we miss the diagnosis not because of failure to detect, but because of failure to include the appropriate gene content. And sometimes we send a test that's just not really appropriate to our question, and then you might end up not just having the wrong kind of false negative where you didn't pick up the right answer because you made an assumption about the genetic architecture or the origin of the disease, but sometimes you end up with incidental findings that actually cause more harm than good. So speaking about panels not being created equal, here's an example. So these are all different commercial immunodeficiency and cytopenia panels you might see. And if you look at the fine print, you'll see that they actually have different limitations that they'll write on their websites. And they also offer slightly different forms of detection that are guaranteed. Pretty much they all use a similar kind of technology, but some of the nitty-gritty things are different. So this is from a review that we wrote for ASH that gives some examples of some different ways in which people might have scenarios where one test might be preferred over another. I'm not going to walk you through this, but feel free to contact me after if you'd like the PubMed ID link. Some really important considerations when we think about genetic testing strategy, of course, are there features of the locus that might affect how you detect that locus? So if there's high homology sequence, you might need some orthogonal strategies on your genetic test to be able to even pick up that gene or that region. And if there are, non-unique sequence reads on short read technologies, most of them often get discarded. So it's important to be aware of that. Another one is if you have relevant non-coding variants that you already know are disease-causing for that gene, or structural and copy number variants. Some of these may not be amenable to short-read sequencing either, and you might need to use other strategies. And these are rampant across immuno-heme disorders. It's also really important when you're interpreting results not to forget about the nature of your diseases, right? So sometimes you'll expect family history to be looking a certain way for diseases like primary ALPS, but it may not, okay? So do not be misled by assumptions about what genotypes and phenotypes are when you're thinking about terms like ALPS, because sometimes people might be applying them to mean different things. Somatic mosaicism is another consideration we have to deal with increasingly because they're not just relevant to cancer. There's sort of different buckets of somatic mosaicism that might arise in non-malignant disease world. Oftentimes they're either there because they confer a fitness advantage to cell lineages that will then grow and proliferate, and oftentimes these cause a lot of immune dysregulation and inflammatory types of disorders. Sometimes these mutations rescue fitness defects in, for example, genome instability conditions, and you might have a hard time actually picking up the very low allele fractions that some of these exist in. So you have to think about, is the sample that I'm taking the appropriate sample, and is the technology I'm using going to be appropriate for detection of these lower allele frequency variants? And certainly, as our next speakers will talk about, this really has a lot of impact on not just the counseling for the patient, but also assessment of family member risks. I'm going to skip this. This is just an example of the many kinds of potentially somatic mutations that arise in our disease domains and how to think about them. When we put all of this together, you also end up with reports where you're still having to do some evaluations because a lot of the kinds of genes we deal with may be associated with more than one mechanism of disease, and sometimes the alleles themselves are associated with more than one effect. So you're not always just done once you get your genetic testing report. Sometimes with VUSs, you have to think about how you're going to do your validation. If you have situations like this, you have to ask yourself, well, what is the specific mechanism that I need to try to interrogate further for this particular gene and this particular variant, and what are the pitfalls of that assumption? This is an example of a patient that I cared for who had a lot of different kinds of clinical diagnoses before I was handed a piece of paper that said that he had a likely pathogenic de novo variant in the Icarus gene. Then, of course, I stood there and said, oh dear, we know that Icarus is associated with at least 7 different disease-causing mechanisms of various flavors. I'm not sure I can assume that it is this particular loss of function form that causes this complicated CVID type phenotype. Let's find out if maybe there's other possibilities that might lead to other kinds of therapeutic ideas. So it turned out that he actually had this increase in DNA binding, gain of function kind of mechanism to his disease, and that really made us think differently about how to treat him. When should you consider really broad, upfront first-line NGS? I would actually argue, and I do this in my clinical practice, that anyone who has genetically driven immunoheme disease should be considered for an exome or a genome if available, and certainly anyone headed for something like transplant. And the reason is because our disease domain has a gene space that's incomplete, rapidly evolving. Our patients oftentimes suffer through very costly and time-consuming diagnostic odysseys, and they have interventions, and a lot of these interventions may be time-sensitive to implement. So a lot of these features really check out when we think about our particular kinds of diseases. So if it's available to you, really do try to look into the possibility. In general, it's also important to think about timeline in order to understand how we strategize genetic testing. If we're dealing with prenatal genetic testing or pre-implantation genetic testing, there's a very, very short timeline before the person needs to conceive, before the person needs to deliver a fetus, right? So there you have to think really hard about how you're using your resources to try to get the family an answer and get them a diagnosis in a time-sensitive manner. This is very different after the patient is born when you're doing something like genetic screening versus carrier testing versus diagnostic testing. So again, it's important to think about where the element of time comes into play, because regardless, a lot of the same technologies might be used across the spectrum, but how you use them might be different. Pre and post-test counseling is incredibly important for genetic testing, okay? And I'm just going to focus on that for DNA-based tests here. Oftentimes, we want to make it very clear to our patients that there are not 2 yes or no black and white outcomes, but there's often 3. So yes, there is situations where we can get a definitively positive result for our patient. We found a spelling change in a gene. The spelling change seems to be damaging to the gene, and the gene seems to be related to their disease in a way that makes sense. So in that case, we think we found at least a contributor to the patient's medical problems. This happens for about 3 to 4 out of 10 people that we really think have a genetically driven problem, okay? So that is not a high diagnostic yield. It is very important to emphasize that. A lot of patients are going to end up with a negative result where they found absolutely nothing that seems to contribute to their clinical problems. But the problem there is that we want to make sure they don't assume that means they don't have genetically driven disease, because not detecting it does not mean there is no change that we just failed to detect. And then, of course, there's this gray zone result called a variant of uncertain significance, where maybe they found something and it's a spelling change that seems to be different from the person and most of the rest of the population, but we don't have enough data to say it's really disease causing. It might still just be just a random spelling change that's not harmful to the person or to that gene. So in that situation, it's really the provider's responsibility to tell the patient how much sleep they should be losing over that. And if they really think it is suspicious, thinking about what additional things you can do to try to prove that. And sometimes that variant of uncertain significance is in a suspicious lesion where the gene maybe hasn't been ironclad proven to be related to that patient's disease phenotype. Okay, so that can happen as well. It's a little bit less common. When we get broad genetic testing, we have to ask patients and we have to counsel patients about certain elements of consent. So if there's a trio, we need to get individual consents for each participating family member as well. We have to tell them about the Genetic Information Non-Discrimination Act, which protects them from discrimination on the basis of employment or healthcare insurance if they choose to have genetic testing done, but it doesn't protect them from discrimination for other things like long-term disability insurance or life insurance. So maybe if they're thinking about getting life insurance already, it's something to do before you do the genetic testing. We also have to tell patients that there are certain things, I guess you could say fringe benefits available that's kind of already embedded in the data generated for that test. This includes secondary findings, which is a list of medically actionable conditions that the American College of Medical Genetics has decided we should really offer anyone getting this broad test, because these are medically actionable things that you can do something about if you have one of these conditions. And they may have to do with things that have nothing to do with the reason for testing, but there's still things that might affect a lot of family members as well. Some examples are cancer predisposition genes like BRCA, reasons why someone might have early cardiac death from a structural arrhythm or a cholesterol kind of problem, and some rare metabolic diseases, reasons why someone might have a bad reaction to anesthesia on the operating table, things like that. We also have to counsel that there might be the exposure of unknown consanguinity or non-paternity or non-maternity for patients undergoing genetic testing so that they're not surprised. And then we also have to ask whether these families will allow us to have access to their raw data, for example, for reanalysis if the testing comes back negative or inconclusive. And we have to ask, do you want to be contacted in the future if there is any opportunity to get relevant research for something that might have been found on the proband's genetic testing report? And usually that's done in a very de-identified way. No one knows who that patient is. No one knows how to reach them directly. They have to recontact the ordering provider and go through the ordering provider to get to the patient. So this is what a standard, you could say, short read sequencing workflow tends to look like, regardless of whether you're talking about exome, genome, or a gene panel. This is the ideal situation, right? That you get your patient from pre-test counseling and a clinical evaluation to a definitive diagnosis where you provide responsible post-test counseling and reverse phenotyping to understand your patient's specific expression of disease. However, this doesn't happen for a lot of our patients, right? And this goes back to some very important reasons that you should understand and that you should be able to convey to your patients. One is the simple issue of phenotyping, okay? So like I said, genetic testing is not a magic bullet. It can only give you the kinds of answers that are going to work for what information you gave them or what you put in. This is just like AI, okay? So the more inaccurate or imprecise data you give, the more sort of secondary phenotypes versus primary phenotypes, the more irrelevant or maybe not true information it gets, the more you're likely to have red herrings. If you give the genetic analysts phenotypes, they'll look for genes related to those. But if you don't give them a feature of disease you had wanted them to look for, they couldn't possibly have known that they needed to look for genes related to that. They also can't discover novel gene-disease relationships because that would be in the realm of research. Limitations of technology are rampant, and I sort of mentioned that, short read sequencing has problems detecting some of these kinds of issues. That's probably the most easily solved issue, because if you can detect it, you still have to know how to analyze, how to prioritize, and how to triage those variants. And in addition, we're sort of in this we don't know what we don't know land with reference genomes and reference population diversity and representation. We have a lot of assumptions about genetic architectures of disease that are probably not true. We certainly have incomplete genetic landscapes for most of the clinical phenotypes we know about today. And a lot of times that sort of symptom or feature matching approach that might work for dysmorphology certainly does not work for immunoheme disorders, where there's so much overlap and so much variability of clinical presentation. So these are all things that it's important to be aware of. Moreover, even our variant classification framework has limitations in terms of fitting the appropriate genetic paradigms for our diseases. So where we end up being is sort of stuck in this sort of variant classification world. And it's important to realize that this is actually a framework that was developed only very recently in the past 10 years. And it was developed so that there's better communication across people and slightly more objective understanding of what, when we say something is pathogenic, what that actually means, okay? So variant classification or interpretation is the job of a genetic lab analyst. They have to process and aggregate all of the evidence about that variant and that gene to assess the likelihood that the variant they're looking at is causally associated with a given disease and inheritance mechanism. However, ultimately, it is your job as the ordering provider to provide the clinical interpretation, which is the most important part. And this is when you have to assess whether that variant in that gene that was found is actually associated with disease or disease risk for your patient. And you might have VUSs that are truly disease-causing where you decide to proceed as if that variant is medically actionable, and that would be totally, totally valid. You might have pathogenic variants where you think they're totally irrelevant to your patient's condition, and ignoring it might be totally valid, okay? So variant classification doesn't dictate what to do about those variants. It simply tells us how much evidence we have right now on whether or not that variant is disease-causing. Now, there's a lot of different kinds of data that get encoded into how we assess these variants, and this is evolving in real time. So there's actually an updated framework that's going to be instituted this year that is going to sort of help reconcile maybe some of the current conflicts and redundancies that we see with our current framework, but most of the streams of evidence are still the same. They still think about things like, what's the nature of the variant? What population and family data do we have? How is it related to other known variants? And what are sort of the mechanistic or predicted or experimental kinds of data we might have? And this tries to convert it into a language everyone can understand in terms of pathogenicity data. So we still have so many VUSs to deal with, even though we actually have probably more cellular and functional assays compared to other disease domains. And the reason for that is partly also because the current framework is not one size fits all. So these particular criteria that we use for variant classification actually leave open a lot of room for subjectivity, but they also fail to accommodate a lot of our genetic assumptions that might be relevant to our particular diseases. And that's kind of also where ClinGen groups come in to try to make more gene and disease-specific recommendations. And at the end of the day, it's just really important to understand, even if you're dealing with a very frustrating VUS, that we're treating the patient. You're treating the patient you know best, holistically from the perspective of all their information. You're not treating their genotype, which is really just one piece of information that can help enhance your management, but isn't going to dictate it. So hopefully that was helpful. I encourage you guys to make use of this particular review if it can provide more examples of what I was talking about. And feel free to reach out if you have any additional questions. I appreciate your attention.
Thank you so much, Dr. Peng, for that wonderful presentation. I now have the pleasure of introducing Kristin Zajo. Kristin has been a genetic counselor in the Division of Hem/Onc and Bone Marrow Transplant at Nationwide Children's Hospital since 2015. She has a special interest in pediatric bone marrow failure and improving access to genetic counseling for benign and malignant hematologic disorders in children. So I'll now turn it over to Kristin for her presentation on effective approaches in conveying genetic testing results.
My name is Kristin Zajo. I'm a genetic counselor at Nationwide Children's Hospital. in the Division of Hematology, Oncology, and Bone Marrow Transplant. Today, I'll be talking about effective approaches in conveying genetic test results to patients and families. I have no disclosures. And our primary learning objective today will be that at the conclusion of this talk, you'll be able to apply effective communication strategies, many of which you may already use when disclosing genetic test results to patients and families. So I want to first talk about why communication matters when conveying genetic test results. And it may seem obvious, but we know that genetic test results can have significant medical, psychological, and familial implications. And unlike many other laboratory results that providers may be comfortable with disclosing, genetic information can affect not only just that individual patient, but their relatives and their relatives' health as well. So effective communication is critical because genetic test results can influence medical management and screening, and misunderstanding results can lead to unnecessary anxiety, but on the flip side, false reassurance. And so we certainly want patients to understand that a negative result may not mean that they don't have the condition or they don't have a health risk associated with the reason the testing was ordered. And conveying that information in a very clear and accurate way becomes key. Patients also need to be able to communicate results to their relatives, and not just so that their relatives understand what's happening with their health, but also so that relatives can use that information to make their own healthcare decisions, which is a bit unique compared to other types of medical results. And then ultimately, the decisions that patients make about surveillance and their adherence to surveillance, prevention, or treatment may depend on them understanding the results and fully understanding the results. So clear communication helps patients make informed decisions and reduces confusion and distress when results are being received. So I know this is primarily a conversation about results disclosure, but I want to start by asserting what is one of the key pillars of genetic counseling training, which is that effective results disclosure really begins with effective pretest counseling. Overall, effective pretest counseling improves patient understanding, reduces distress, and enables clear communication of genetic test results. So really that conversation should be happening before the testing is even ordered, so that when the results do come in, there's a much more clear conversation and a much more clear path forward for the patient. There are some key questions that should be answered in a pretest counseling session, and they include many of your standard who, what, where, why types of questions. First, why is the testing being recommended, and what will happen if the testing is not pursued? Can the treatment proceed as planned, or does the treatment really hinge on the results of these genetic tests? What testing is being ordered, what's covered, and what is not included in the testing? And sometimes what's not included in the testing can be just as important as what is included in the testing. For example, if you're testing a patient for hereditary bone marrow failure, but the family has a very strong history of Huntington's disease, it can be important to go through with the family that Huntington's disease will not be included on that testing. And that way the family is able to accurately interpret the test results and also can have realistic expectations about what the testing is going to show. And so this is where it can be really important to get to know families, understand the family history, and what experience a family might have had with genetic testing previously as you're considering a test for a patient. We also ask the question, could genetic testing lead to more testing? So we'll talk about that on a future slide, but is this genetic test that you're ordering going to be the end-all be-all for the patient? Or could there be subsequent tests that come of this particular test? And so patients understanding that this might be one part of a more extensive workup, or that at times there can be testing that may follow this initial test, can be really important as they adjust their expectations around what they're consenting to. When will results be available? So it's very important to know the timeline for the test that you're ordering to give families a realistic estimate. Understandably, genetic testing can feel like a really big deal to patients and families. And even when a test or the results may feel inconsequential to a provider in terms of impact on treatment or care, for a family, they'll often say that's the only thing they thought about for the weeks leading up to the result. And so knowing a clear timeline of when to expect results can help reduce some of that anxiety and ambiguity as they wait. And then who will communicate the results and how? That's important to know both from a provider standpoint and from a patient preference standpoint. So I often suggest it can be helpful to ask patients how would they like to receive those test results? Some patients prefer to get a message through the medical chart first from the provider so that they can process the written information before a phone call. Others would like to receive a phone call as soon as possible once results come in. And so when families have all these questions answered up front, at the very least, it eliminates the aspects of uncertainty that we have control over throughout the genetic testing process. So I want to come back to that concept of when genetic testing might lead to more testing with a patient example. This patient had a large gene panel which revealed several variants of uncertain significance, or VUS. At first glance, this is nothing too surprising with a large panel. We know VUSs are very common, especially when you test lots and lots of genes. However, upon looking more closely at the variants, each variant was a gain of the entire coding region. As it turns out, looking at these variants in more detail, each variant also occurs on the same chromosome, chromosome 8. So as a result, this patient underwent additional genetic testing, including a microarray and a karyotype, both on blood and several additional tissues, which ultimately confirmed the diagnosis of mosaic trisomy 8. And this is important because this diagnosis has significantly different health implications and reproductive implications than a variant in any one of those genes reported alone. And it really highlights how this one genetic test led to a lot of downstream investigation for this family that they may not have been anticipating. And it can be hard to predict that this may happen. And so what's helpful is to just tell families up front that the results of this genetic testing could be helpful, or they could help guide us in a direction that may require more investigation so that they have that realistic expectation up front. So there are several challenges that can make communication of results a bit more complicated. The first is complex terminology. So this can make results difficult for families to understand when they don't have a concept of words like variant, pathogenic, penetrance. These words may not be intuitive for families, and it's important to clearly define the terms, even if you perceive them as common knowledge. Second, uncertain results, such as variants of uncertain significance, can be really difficult to explain because they don't provide a clear answer. And there's not a lot of other aspects of medicine that have this degree of uncertainty for families when they're receiving results. Third, emotional responses can impact comprehension. So we know patients receiving genetic test results, of course, may have the same range of emotions as those receiving other types of medical results. So you could have anxiety or fear or sadness. But when dealing with genetic disease, there's also a really prominent component of guilt, worry about passing this on to the children, or guilt that maybe I could have done something more if I would have known sooner. But also relief. We have families who, even when they have a positive test result, may feel relieved that it represents an end to the diagnostic odyssey they may be on for years prior. And so I think it's really important to not make assumptions about how a family may respond to a particular result, but to give them space to process those emotions and think about how it may impact their ability to comprehend test results there in that moment. And then finally, time constraints and differences in health literacy can make it really difficult to ensure full understanding during a single appointment. And so being available as a point of contact to families over multiple time periods and making the effort to check in and revisit results at subsequent appointments to ensure comprehension really helps adapt your communication and make families better able to process those test results in real time. There are several key principles that can improve the effectiveness of a genetic result disclosure. And a lot of these conversations can be structured really similarly to other types of medical disclosures with a few key differences. First is really just setting the stage, assessing a patient's baseline understanding of why a testing is being ordered. What do they remember about conversations leading up to ordering that test? And then delivering the results clearly. So using plain language whenever possible, avoiding technical jargon, and explaining concepts in simple terms. Give a high level result in straightforward language up front, and then explain more detail to follow up. Use visual aids whenever you can. That gives families something to reference that helps them attach the words that you're saying to something that they can visually see, can make a big difference. And always have a copy of the test report for the family. This lets families jot notes down in the margins or attach to each variant that was found. And this can be a really helpful tool for families to reference back at a later time when they go home and try to reflect on the conversation. Explain the meaning of the results. What are the medical implications? What are the implications for family members? And explain more than you think you need to. I think the more providers get comfortable with this language and the world of genetic testing, the easier it is to make assumptions about what a family may understand and what they don't. And so it's also important to check back as much as possible with the family throughout the conversation. Check in for understanding. Use teach back methods. Ask the family to tell you what they heard. This way you can address a misconception in a more time-sensitive manner versus letting it run through the entire results disclosure. And then ultimately provide next steps and resources for a family. Do they need to change screening? Do they need to contact family members? Do they need to be referred to another type of provider based on their results? And if there are resources available, be prepared to connect them to those resources. Is there a support group that you know of? Is there a website for patients with a particular condition? Are there other patients at your hospital that potentially they could be connected to? Families are often looking for, what do I do now at this point? And so being prepared for those questions at the results disclosure can be really helpful. So different types of genetic testing results require different communication approaches. Of course, anytime we have a genetic testing result, there's really three versions of that result that we can have. The first is a positive result. A positive result means that we found a pathogenic or likely pathogenic variant. This requires a really clear explanation of the associated risks, the screening, and the implications for family. And it also requires the clinician to be very clear with the patient about whether this result actually explains the full patient phenotype or maybe just part of their phenotype. What does this mean moving forward for potentially their future children or other people in the family who may be at risk? A negative result should be explained carefully to avoid false reassurance. We talked about that previously, but certainly we want families to understand that just because a genetic test result is negative doesn't mean they're undiagnosed with the condition that may have led to testing, doesn't mean that there's no genetic risk involved. It may just mean that we haven't been able to find the answer with this type of test. And then uncertain variants or VUS. These may need further investigation, but it's important to emphasize that a VUS is not considered a disease-causing result and should not guide medical management unless new evidence emerges. So this can be really important because lab reports sometimes don't make this distinction really readily apparent. And following the passing of things like the Cures Act, patients often gain access to these test reports before the provider has the chance to communicate them. And so as a result, you may have a patient who opens a test report on a Saturday evening and sees something like this. So even for families with a really high health literacy, navigating a report like this with multiple variants of different classifications can be really daunting. Patients have often been waiting very anxiously, counting down the days for results, and then the first thing their eye will be drawn to on a report like this is the big positive at the top of the screen. But we have to really put that result in the context of the patient and the reason for doing testing. So in this patient's case, the testing was ordered due to a concern for familial HLH. A large immune dysregulation panel was ordered by the inpatient team for this patient while they were admitted to the hospital. And while the result is technically positive, really it's positive for a pair of variants that when combined causes G6PD deficiency. So although this disorder can have an impact on a person's health, this is really not related to the test indication and would not be expected to be the primary cause of the patient's symptoms. So I would actually call this positive-ish for this report. You'll also note two additional variants classified as pathogenic and likely pathogenic. Each of these is in a gene that's inherited in an autosomal recessive manner, meaning that although it is relevant for reproductive risk, it would not be expected to cause disease in this particular patient. That information is present in the text above, but it's not highlighted clearly in the table. That may be the first thing that patients are looking at when they see this long list of things that they perceive might be wrong with their child. And then there are several VUS that would also need to be assessed. But taken together, a report like this can be really overwhelming for a family. And it can be really helpful for providers to prepare families for VUS, and then have a copy of the test report available so that they can, review these results, write these types of things down. So you may see them actually scribble in the margin, this is not related to why we did the testing, something like that, so that the family has some context for this later when they go home and they're trying to explain this to other family members or trying to explain it to another provider they may see with their child, or in the event of adult patient, another provider they may see. When we talk about communicating risk, this is another real key component of result disclosure. Patients often struggle to interpret things like percentages and probabilities, even though we may know them. And so it can be helpful to use an absolute risk rather than a relative risk. So instead of saying your risk is increased threefold, saying normally about 1 out of 100 people develop this condition, but with this genetic change, about 3 out of 100 people may develop it. That gives a family something they can more easily visualize, something that's more comfortable for them to think about. Again, provide visual aids whenever possible, including things like risk charts so that they can visually see how different those risks may be. And then compare the risk to familiar scenarios. So the most common example is thinking about flipping a coin, heads or tails, for a 50-50 chance. But there may be other scenarios that make sense in the context of a particular family that you can use to help make results a little bit more palatable. And then put the findings into context. So lots of patients overestimate the rarity of genetic findings, and it can actually be reassuring to families sometimes to hear, we see this frequently, this is not something that's a cause for concern, or we have lots of experience treating patients with this condition, so that they don't feel that their child is, 1 in a million every time they find a genetic variant. And then I also always say use silly examples. These are two that I use pretty frequently in our clinic, both with adolescents and adults, and ones that families have said are the thing that they use to explain to other family members and that stick with them. And so the first example is when you're explaining something like a point mutation, you may have a sentence that says, put a hat on the cat, and now you have a change in that sentence, a single letter typo that now says, put a ham on the cat. So one single letter change in that instruction is enough to totally change how the body interprets that instruction. And so this can be a way for families to understand how just one single base pair change or one tiny typo in the DNA is enough to cause a genetic condition. And then similarly, when thinking about something like a VUS, I often will reference the word gray, in that it can be spelled Grey or Gray. Either way, we understand the meaning of the word. And the body has changes like that too, where you have a spelling change that doesn't change the way that the body interprets that instruction. And so these very simple, seemingly silly ways to explain something can make a big difference to a family in kind of putting things into context, thinking about things in a way that they may be able to then go explain to someone else. And using teachback with families, I'm always amazed at the ways that even when we think we're communicating clearly, patients may interpret genetic terminology very differently. So I think the most prominent example from this list that we hear frequently in our clinics is patients being told that they're a carrier of a condition and misinterpreting that to mean I have the disease. And we even had a family say to us, I mean, if I carry an object, I have the object. So if I carry the disease, I have the disease. And so it's easy to understand how a family might misinterpret that information just based on their real world experience. And that's why it's extremely important to not only provide accurate information, but to make sure the patients actually understand what those results mean for their health and their family, to say it in terms that really make sense for a carrier to be able to say, you don't have this condition, but it may impact your children, and here's why. And so really thinking about these words that we're choosing and how a family might receive them, even if we think we're being clear, can help inform the way that you structure your conversations moving forward. And then another somewhat unique service that genetic counselors provide is really helping to go beyond that patient encounter to support family communications regarding a hereditary condition. Because genetic information is shared within families, patients often become the messengers of really important health information. But many patients are not sure how to communicate those results to their relatives. So, genetic counselors often support this process by providing written summaries or family letters, identifying which relatives might be at risk. And sometimes that's as simple as sitting down with the family tree and saying, here are the people I think you should contact. And then offering guidance as to how to start those conversations, especially because sometimes they may be uncomfortable. We often will even help draft things like a Facebook message or a text message to try to help families get some wording around how they're going to convey that information to their relatives. And then offer to refer relatives for genetic counseling wherever they may be, if that's helpful or relevant in a particular case. And the more we can help patients share accurate information with their family members, the better total genetic care we're providing to that patient and their family. And I want to just briefly touch on communicating genetic test results to minors. I do work in pediatrics, so this is something that's near and dear to my heart. And communicating genetic information to children requires a slightly different approach than counseling adults. For young children, explanation should really focus on what the condition means for them right now. So we do talk to young kids directly, but we really focus more on how this genetic test impacts why they need a certain medication or why they need a blood test or why they need to come to the doctor. But we save those complex discussions about inheritance or long-term risk until they're a bit older in most cases. School-age children can begin to understand basic biologic concepts, such as the idea that our bodies use genes as instructions for how cells work. And kids at this age really can get fixated on whether something can be caught. So, for example, if you have a genetic condition, can your friend catch it from you? So we do some education at this age around inheritance and the fact that you have to be born with a genetic condition. It's not something that you can pass between friends. By adolescence, kids are usually ready for more detailed conversations, and this can include discussions about how the condition's inherited, what the future health implications might be, what this might mean for their reproductive risk in the future. And it's really important to recognize that these conversations about genetics should be ongoing, not one-off discussions. As children mature, their understanding evolves, the information can kind of be revisited in increasing detail. And adolescents really seem to appreciate being involved directly in the conversation. So we try to spend a lot of time respecting their developing autonomy, having those direct conversations with them and getting some feedback from them about how much information they want at a given time point. And this helps build trust with them and ultimately improves their engagement long term in their own healthcare as they're transitioning to adulthood. So to wrap up, just some key takeaways from today. Communicating genetic test results is a critical component of genetic medicine, and providing clear, patient-centered communication helps improve understanding and reduce anxiety. We recommend using structured conversations, plain language, and visual aids to help enhance comprehension. And written summaries can be really helpful to follow up and reinforce patient understanding and help minimize some of the challenges that may come with the emotional reactions upon initially receiving results. And ultimately, effective communication helps just ensure that genetic information can be used to support informed medical decisions and improve patient care and that relationship between patients and providers. So with that, I thank you for your attention today, and I look forward to taking any questions at the Q&A later today.
It's now my pleasure to introduce Dr. Shane Quinonez. Dr. Quinonez is a clinical associate professor at the University of Michigan, where he specializes in pediatric genetics with a focus on inborn errors of metabolism and conditions identified through newborn screening. He serves as the director of Global Reach, leading initiatives to expand access to genetic services and training in resource-limited settings through international collaborations. His work centers on building sustainable clinical and educational programs that improve the diagnosis and care of children with genetic conditions worldwide. Dr. Quinonez will be presenting on techniques for assessing comprehension of medical results.
Hey everyone, thanks so much for the opportunity to speak today. My name's Shane Quinonez. I think you had an introduction of who I am, but I'm a pediatric biochemical geneticist at the University of Michigan. And the talk I'm going to be talking about is techniques for assessing comprehension of medical results. I know you've had a lot already today on results and sort of specialized in genetic results. And so hopefully this is a complement to all of that, because it's one thing to speak to a person about these results, and then it's another thing for them to actually understand it. So hopefully we'll dig into a number of different aspects in that space. So as far as learning objectives go, there's a number of things here. We're going to touch on a number of things, probably a couple different ways to hopefully hammer home some of the points. But really, I want to first start by differentiating patient satisfaction, meaning I really like this visit, from demonstrating understanding, which is I can actually do something with the information that was provided today. We're going to talk about a closed loop toolkit, so teach back and chunk and check and documentation of those things, and how you use those in routine and high risk encounters. And then another thing, especially today in 2026, we're really going to try to get a sense of what it's like to practice in our current environment where there's a lot of like artificial intelligence that patients are using when it comes to results, and also portals, so access of results before we get a chance to relay those results, and how we actually like deal with that aspect of care. And so I really want to kind of at least just highlight those aspects of things right at the beginning, because I think these are going to become more and more of a reality. And to that end, there's a couple like statistics here in the references at the end, but 96% of patients prefer immediate portal releases of results. And no longer is it the case where I receive results, I can sit on this result, think about it, and then call the patient, and that's the only way they access it. A lot of times, a patient has seen the result before I'm ever able to talk to them, and they formed their own interpretation of things. And so the first part of the conversation or the visit is actually figuring out what that is. And as you can imagine, these abnormal flags worry patients before appointments, and they may have their own interpretation. And so I often start a lot of my visits with, so what have you already seen? And most of the time, the conversation rarely begins at zero. So I'm already starting from a place of patient understanding or potential patient understanding. And then as it pertains to AI, and these numbers are just going to increase, about 17% of adult patients use AI chatbots monthly for health information. And about a quarter of adults between 18 and 29 use AI for health questions monthly. I'm sure everyone can think about their own personal life. I know my brother is notorious. He's definitely within this 25%, even though he's older than 29. And so people will often, and this happens weekly for me, will say that chat said, or when I looked this up in AI, it sort of said this thing. And a lot of time it's about normalizing the use of AI, but really giving patients guardrails to operate between when they use AI for their medical care or interpretation of these results. And we'll talk about that over the course of this talk today. Okay, so getting a bit into why this all matters. There's the I want to do a really good job, and that's why it matters. And then there's also on the other end of the spectrum, the medical legal aspect of things, and both are actually important. But importantly, consent disputes, misaligned surveillance plans, and incorrect home monitoring most often trace back to misunderstood results. And so there's a lot of actually good inpatient care that we can do when it comes to assessing what a patient knows about the results we're giving them. Importantly as well, so written materials, consent forms, genetic testing reports, average at or above an 11th grade level, well above the AMA's recommendation of a 6th grade target. So that's a really, really important aspect of things. Teach back and documentation are some of the only reliable proof that understanding was achieved. And we use a lot of this earlier in training very consciously, but later in our careers subconsciously to sort of see where a patient falls in the information that we've provided to them. And over the course of my talk, you'll see these sort of key evidence bubbles, and there's sometimes a lot of the same content in the slide, but really are the highlights of the stuff that I'll be talking about today. So when we talk about understanding, there's sort of surface versus deep understanding. And for those that have interacted with patients a bit, you can kind of pick this up pretty readily. So surface level understanding is when a patient will just repeat a phrase or a lab value without context. So for example, if I have a genetic test result and it identified a variant of uncertain significance and I call it a VUS, the patient would be like, yes, I understand this is a VUS, but with no real other deeper understanding of what that means. They can't really connect what that means to an action. And it's important though, because this really catches factual errors. Yeah, it's great that they said it was a VUS and not a pathogenic variant. And so that's a factual piece of information that we can build on, but it really doesn't give that deeper understanding. And that deeper understanding is really how do you apply the results to real decisions? So for example, a VUS means watchful waiting and not actual treatment or surveillance. And that can really demonstrate action for a patient that is something that we as clinicians really rely on when we're assessing if a patient understands a result or not. And it kind of has that both comprehension of the knowledge aspect of things and then the also behavioral intent that is so important when it comes to what a patient does after a clinic visit. And so from a genetic standpoint, there's a sort of like three things that I kind of go through when I think about assessing if a patient understands something or not. First is the actual result type. Can the patient state whether the result is pathogenic, likely pathogenic, so disease causing, or a VUS or a variant of uncertain significance, or negative, and really talk about the gene or the pathway that we're talking about. So that's the sort of knowledge aspect of things, and that's really important. But then I also want to know if they know what that means and the limits of what it means. So do they know what changes as far as their diagnosis or lack thereof, or their risk or lack thereof? And what does that mean about residual risk or uncertainty? And then also the sort of most important, I would say, when it comes to follow-up is the actionability. Can they state the immediate plan, their surveillance, and even if this is a genetic test result, who else in the family will need an evaluation? And really checking all three of those boxes is really what is the main goal when I provide a result or when we provide results to patients. And then it's important to think about why does actually comprehension fail? So I'm going to go through, I guess, what I would call 6 predictable drivers for why comprehension fails when it comes to results. And the first that I'll talk about is health literacy. So literacy limitations across all demographics and educational backgrounds. We also in medicine are notorious for jargon. I mean, I've already done this in this talk. Rather than said a variant of uncertain significance, I've said VUS. And so we do this automatically. So it's really important to know that depending on patients' general health literacy, or in my case, genetics literacy, they may have no idea what a VUS means. And it's really important that I spell it out and just don't use the term VUS. And especially if we're in a stressful situation, an individual's ability to keep up is really, really impaired. So actually the setting is really important as well when we think about some of the stuff that we're saying. We'll talk about that a little bit more. And so a universal precaution is assuming everyone benefits from plain language and structured checks. Another reason comprehension fails is numeracy. So it's really hard sometimes for patients to conceptualize the numbers we throw at them. So percentages, really without denominators, are meaningless for a lot of patients. And portals will often show only a high or a low. And if your range of normal is from 100 to 500 and the value is 502, that's a much different scenario than if your range of normal is from 1 to 2 and your value is 4. So we as clinicians understand that difference, but it can be very difficult for patients to really understand these numbers that are getting thrown around. When we talk about risks, sometimes icon arrays and natural frequencies can really improve recall for other counseling that sometimes happens. So on the right here, you can sort of see a visual representation of what in this case would be 6%, so 6 out of 100. And it really can help patients conceptualize what does 6% actually mean for me and on a population basis. And so, yeah, we can really ask patients to restate things in situations like this, and that can help us assess these things. Additionally, and I've alluded to this already, emotional overload. A lot of times, result disclosures really happen at the exact same time that a super critical and acute medical event is happening. I know that when I'm delivering a result in an inpatient setting versus a clinic setting, there's going to be a complete difference in what the patient's able to retain and process going forward. And as you can imagine, the stress hormones that patients have when they're in the hospital and they haven't been sleeping, this really can limit their ability to retain the information you're providing to them. And so sometimes really useful to start a conversation out with, like, what are you feeling right now? This both like builds contracting and sort of builds a relationship with the patient, but also can give you a sense of, all right, when I'm going to be providing this information, what's a patient able to handle? And so I do think it does quite a bit for helping conversation in a visit. And while you may walk in there with the goal of getting through this whole test report and making sure they understand what the results mean right now for the next couple years and then for the next 20 years, sometime you may just be like, all right, look, this patient is incredibly overwhelmed. I'm just going to tell them what they need to know right now, and then we will deal with the rest on the outpatient basis. And that first question can be something that everybody uses to get a sense of how much information a patient can handle at that time. And then also, and we deal with this all the time, uncertainty. We deal with a lot of uncertainty in all aspects of medicine. And patients and clinicians themselves can really struggle with how to deal with that uncertainty. A variant of uncertain significance is often interpreted as bad news or nothing, and it's neither of them is accurate. And so we just know that it is an uncertain result, and it's really easy to want to categorize it as either bad or good, but it's kind of neither. It's something that's sort of a little bit in the middle and uncertain. Also, things like incomplete penetrance and variable expressivity make probability discussions incredibly difficult when we talk about genetic conditions. Patients really benefit from scripts for explaining this uncertainty to family members and other clinicians. Because a lot of times, let's say we're dealing with a patient and they're seeing us in clinic, their family member would be waiting on those results. And it's really useful for us to empower them with scripts that they can use themselves when they get asked about these results going forward. Also, diagnostic ambiguity. Our diagnoses and our ability to diagnose conditions changes with time. If you came to a genetics clinic in 2004, our ability to provide a diagnosis is much different than if you came to a genetics clinic in 2026. And a genetic evaluation that was negative in 2004 didn't mean that there wasn't a genetic condition available. It just meant that we couldn't identify it at that time. And so it's important to know that just because there's a negative panel, that does not mean, or a negative test, that does not mean that there's no genetic diagnosis present. So that diagnostic ambiguity can be really, really difficult. And it's difficult for us as clinicians as well. And so some patients will often equate a completely negative test with oh, I'm good. Genetics have been ruled out, nothing to do. And so it's really useful to let patients and families know, all right, well, this test was negative, but here are the reasons to come back. So if signs and symptoms change, or if we often say if and when a patient is planning a family of their own in the future, it's worthwhile to get an updated evaluation because we know that our ability to diagnose conditions changes with time. So, patterns. I like to think about patterns as far as things that help us recognize common situations that understanding maybe is impaired and how to intervene. And I chose to, in this case, use a number of conditions that I see all the time. So I'm a biochemical geneticist. And so I see a lot of biochemical test results and biochemical conditions. And so I'm going to sort of use those aspects to go through this. So one of the conditions I see all the time is phenylketonuria. And this is sort of a pattern I see all the time that I'm sure in this case relates to PKU, but I think you all probably have your own examples you could think of. So an example with phenylketonuria, so this is a disorder where phenylalanine elevates and in really young kids results in irreversible neurologic damage. And these levels can normally fluctuate with diet. There's a normal fluctuation. And patients and families may interpret every single fluctuation, especially in younger kids, as incredibly dire and causing irreversible brain damage. And so assessment in this situation really focuses on whether they know what is actually concerning and what is not. And when should they reach out and when should they not? And a teach back method that can be of benefit is thinking something like, oh, well, if your phenylalanine rises above a specific range, or you notice new symptoms, that's when you should reach out to me. Otherwise, things are otherwise okay. And so an example of how this would progress in a patient's case would be a Phi of elevation would be noted. The patient would interpret this very negatively and come to the clinician and we can kind of work with patients in situations like that by instead sort of saying, hey, do you have a sense of what we would do if phenylalanine is just slightly elevated? And get a sense of where they would fall from a concern level and where we would fall from a concern level, and really give them really a threshold to sort of say, hey, if it's not above this level, we're otherwise fine. And here's what you do if it is. Another condition I deal with is MCAD deficiency. And some patients have misbeliefs that in the event there's a normal acylcarnitine profile while they're on treatment, that does not mean that they're at risk for a diagnosis or actually a metabolic decompensation. And we know that that is not the case. We know that even if patients have normal labs in clinic, they're still at risk of metabolic decompensation if they're sick or have fasting intolerance. And so it's important that patients really articulate why a sick day protocol is needed and why fasting limits are important, even when they have normal labs in clinic. And so it's important to probe for these misbeliefs like, oh, my levels are normal now, so the restrictions no longer apply. So it's important to know that sometimes even normal labs will get patients to assume that things are otherwise fine when they maybe aren't. Another condition I deal with is OTC deficiency. This is a urea cycle disorder. And patients with this condition, if they have metabolic stress, can experience hyperammonemia, which really can cause irreversible neurologic damage at any time. And patients really need to have an understanding about what to do when they are sick. And so we take all of these symptoms incredibly seriously. So this is one where patients need to be informed that, hey, if you are sick and you are vomiting, you should be calling us. And so they really need to have these action thresholds. And we need to rehearse them with patients all the time. And this is a relatively common thing for our biochemical patients in that occasionally they will go a few hours or a day without calling us. And in the event that is the case, we often provide them feedback to say, hey, look, we're always here 24/7, 365. If you're vomiting or you're sick, call us at any point to give us a sense of things because this is really, really important. And so sometimes you may not address it in the first visit, but giving that feedback if situations do arise is really important going forward. Mitochondrial diseases, this is a whole topic that I could spend an entire hour talking about. I won't. But we have a lot of information out there regarding mitochondrial supplements and whether they work and do not work. And so it's really important to assess a patient's understanding of what is true and what is their perception based off what they've read on forums, what they've seen on the internet about these things. And so there's a lot of information we can provide for these patients regularly. Okay, how do you actually assess this in clinic? I'm going to go through a number of techniques. So teach back, chunk and check, open progen scenario testing that I've talked a little bit about. And like I said, this is going to be where we talk about a decent amount of scenarios and go through examples multiple times. So just sort of a universal blueprint. I think some just sort of best practices. Really limiting each visit to 1 to 3 key points and repeating them during that visit is really, really important. As you can imagine, a patient and their family, if you are really trying to go through everything about a specific condition with them during every visit, it's really going to be overwhelming. And it's much better to really focus on 1 to 3 key points and repeating them. I have a patient with a very complicated glycogen storage disease, and there's boulders and there's pebbles. And I really want to make sure I talk about the boulders. And if we have time, I get to the pebbles. But the boulders are things like, what are your blood sugars? Are they normal? Are they not normal? How do we make sure you do not become hypoglycemic? And really making sure that I touch that first. And then these other sort of I don't want to call them minor, but lesser important points we get to with future visits if we can't get through those really important 1 to 3 key points early on. Using plain language, visuals, and numbers with denominators when talking about these things with patients is really, really important. And then also, as mentioned, checking understanding every time. And this really is a system of how we do things. It may seem awkward at first, but over time, the more you do it, the more automatic and involuntary kind of is. So again, simplify, explain, check, also document what was taught back. That's also very important. And then repeat. I often, with this patient with this glycogen storage disorder, am regularly going back and talking about the same things because these are very complicated topics. And this patient, their mother doesn't have the highest health literacy. And so it's really important that we're doing this on an ongoing basis. So essentials of the teach back method. So explaining concepts in conversational language. I often try not to say, oh, do you understand this? Because a lot of times patients will regularly just automatically say yes. And normalizing the request. I want to be sure I explain that clearly. Can you walk me through it again? I think that's a really normal thing to normalize for patients to ask. Repeat and recheck until the patient can teach it back in their own words. I often sometimes worry that I sound a little pedantic when I'm talking with patients. It's a worry that I have, but I think the alternative is worse. And another thing that I occasionally will do is, and I've already alluded to this, I will ask them how will they explain this to another family member, and I'll preface it or I'll qualify it to say, hey, my guess is you probably have a lot of people that are asking you questions about how things are going and what the results of this testing showed. Like, what are you going to tell them? And I do think that helps me get a sense of their understanding without seeming like I'm actually like quizzing them, because I think that's a real world situation that a lot of our patients and families find themselves in. So evidence for this. There has been a lot of work in this space, and it's shown that the teach back method is improved self-efficacy and adherence when used. So it's a low risk, low cost, but really you have to be intentional about it. Evidence on knowledge outcomes has been a little bit mixed, but that is improved when you include written summaries, which I just personally don't use as much, but I know it does have a lot of benefit. So the teach back in general, though, does has low risk, low cost, and does actually improve self-efficacy and adherence for our patients. Another thing that we use, and like I said, a lot of us just do it automatically now, is this chunk and check. So it's deliver one idea, check it, then layer the next. This really prevents cognitive overload for patients. This does pair really well with visual aids that sort of highlight, so for example, highlighting each section of a genetic report and then pausing. And then it's also important to document this. When you're actually doing this, it can be really important to have that documented in your note. So the other thing I sort of find is a lot of individuals find that working with an interpreter is really difficult. And I do think it actually is. And I talk a little bit about that over the course of this talk. And I think it's comes with its own set of difficulties as far as patient understanding goes, as we can all imagine. But for me, I actually think it slows me down and does help with this chunk and check. Because I think naturally when you're working with an interpreter, you're sort of saying a little bit of information, pausing, you're collecting your thoughts. The patient sort of can then interact with the interpreter. And I do think that that is something that is introduces this sort of natural chunking. But if we can sort of do that on our own when we're going through our counseling or discussing treatment with patients, it's really, really valuable. So when you're going through this long list of labs, I really try to take it one section at a time. We're going to talk about the plasma amino acids right now, or we're going to talk about the CBC right now. So here's what I'm seeing. Do the CBC aspect of things, see where they're at after that information has been conveyed, and then move on to the next one. It's important to discuss the risk of that. Same thing with risk. So when you have risk discussions, I think it's probably even more important than from a lab standpoint, because I think that's really getting into action after all of this as well. I use open-ended probes as well. And the goal here is really to not say, do you understand this? The really is to try to elicit genuine understanding. Some examples of what you could say is, walk me through what you think this means so far. I really like that as a thing. Or when you explain this to your partner, what did you say? What worries you most about this result? And it's like I said, you really want to try to be curious about this. This is not just a box you are checking. You're really interested in trying to figure out where a patient's at with all of this. And this, like I said, I've already alluded to the one of, oh, when you talk to your family about this result, what are you going to sort of say? I often work with a genetic counselor. And my first question, I could probably word it better, but my first question when I walk back into a room after one of my counselors has talked with a patient and their family is, hey, so where are you at with all of this at this point? It's maybe too open-ended for what it's worth, but I get really useful information back. I even ask, hey, this is a lot of information. Are you overwhelmed, underwhelmed, whelmed by this? And I think those open-ended probes really give me a sense both from a knowledge standpoint, but also from an emotional standpoint, where a patient's at with all of the information that has been conveyed. And often that question is, for me, what dictates whether I say to a patient, hey, why don't we schedule another return visit in 6 months to check in about this? Or if a patient's like, oh no, this is completely aligned with what I knew ahead of time. This has been great. Then I can actually let my guard down and I'm not as concerned that a patient is really completely overwhelmed and not absorbing any of this. So hypothetical scenario testing. This can really help when we're talking about, like I said, my biochemical patients. This is a great example of where I think that there's a lot of benefit to sort of closing the loop with some of the topics that still remain unanswered. So using future-oriented questions to really force application. So if your ANC drops again, what happens next? This really can identify if a patient can operationalize the plan versus just like repeat it and document when you discuss this and they're part of the care plan. That's really the case. We have FYIs and metabolic care plans that patients take with them to the ER that sort of documents what we're going to do. This care plan is really, really useful for patients' care, especially if they don't live locally and they're at a different hospital. So risk reinterpretation. Ask patients to restate these risk numbers and comparison groups, those icon arrays or other visuals to really anchor probabilities, correct misinterpretations. People that sort of see a 50% risk and that means, oh, I have it. If patients undergo a genetic test and it's negative, well, yeah, there may be some residual risk, but it's pretty low versus it's a variant of uncertain significance, maybe that we're a little concerned about. Wait, we're going to watch this one pretty closely. Or if it's a diagnostic test result, hey, here's a plan that we're going to do. And it's really important to try get us to get a sense of how a patient understands risk because everybody is different in this. Some people think 10% is that's my least favorite percentage, by the way, 10%. Because some people think that's, oh gosh, that's pretty high. Other people are like, oh, that's super low. And it's really important when you're talking with patients and families to get a sense of where they fall and what they think about that. And this is always in my back pocket. I don't personally use it as much as I would like, but a written summary verification. I think that this is something, especially when we're getting into really tricky territory, that can be useful. So co-authoring with a patient and their family a brief summary. So what should we write down as the takeaway? A lot of our visits now have after visit summaries, and this is a perfect section to co-author a brief summary or a plan going forward. And then you can sort of read the summary together and put it on the portal, as mentioned. And sending a follow-up message with sort of some points later to reinforce this is also incredibly valuable, an option that's always should be in your back pocket. Visual confirmation. So walking patient through family-friendly report templates, if those are available, are incredibly useful. I think it's every time I have a genetic test report that I go through with a patient, I print that report out and I sit down with them and we go through it together. That's not because I expect them to retain everything. I just want them to have known that all of these things are understandable. And I want them to remember, hey, when I went through this with the doctor, I felt like I understood it. I wasn't as overwhelmed by it. So the next time they go through it, they can kind of tap into those same emotions and feelings rather than just being completely overwhelmed. What you really want to do is highlight the important results, what they mean, and next steps with every section. This is going back to that chunking of information. And then again, asking patients to explain what this means to you. Another great time to say, hey, you've got this. You're going to walk home with this test report today. When your dad asks you the results, what are you going to tell them if you want to share this with them? That can provide so much information. But I do think it's really important that our patients are provided with a copy of the test results, and then we get to go through it with them together. And then digital follow-ups. I use this not super often, but pretty regularly. When a patient is incredibly overwhelmed, and I could see that it was very difficult for them to sort of process all of the information, and I've already set them up for a return visit to come back. It also can be beneficial to circle back with just a quick portal message if you have the time. hey, what did you understand? What are you doing with this information? And where are you at? Do you have other questions? Track these responses to identify who needs maybe a nurse to call back or a genetic counselor to call back or another reply in the portal. And then asynchronous checks really capture those who don't really pay attention in the clinic, but absorb the information later. It's very interesting in that sometimes one of the questions that I often ask involuntarily in a visit is, hey, do you have any other questions? A really common response I get is, I don't even know what question I should be asking. And that's makes so much sense when you think about it from a patient perspective. And so asking patients, hey, write your questions down and we'll take a look at it later is really, really valuable. This happens definitely on the inpatient side. When patients give them a result, a patient an admitted patient, you give them the result and they're completely overwhelmed from the admission itself, encouraging them to write the question down and maybe you can come back at a future time or they can send a portal message after they've sort of digested all of this. I often describe genetic test results as the genetics as a whole is sort of drinking from a fire hose. It's really, really, really hard to digest all of it. And these sort of follow-up checks can be really valuable when assessing for patient memory. There are a couple screening tools that can be used. I just listed a couple here. That one is called RealG. There's a single item literacy screen that can really identify patients who need a little extra assistance. This can help plan more time or involve others to help with patient understanding. And if you do this, it should be, again, useful to document those so that you sort of have a sense of where a patient falls on this spectrum of understanding. Okay, so I'm going to talk a little bit about AI and portal considerations. I know I talked about it at the beginning a little bit. I want to come back to it right now. So for the patients and families that use AI, it kind of looks like this. A result is seen by a patient. Patient sort of looks that result up on the internet, often accessing AI. I mean, if you Google things now, you get an AI interpretation automatically. This sort of changes their thoughts and then they come to clinic. So you really have to get a sense of, hey, what did you look up and what did it tell you? You really want to calibrate for accuracy and privacy because privacy concerns are a major issue. I mean, if a patient chooses to put their information into a chatbot, that's on them, but it's useful to actually give them a sense of things. And you really want to encourage them to use authoritative sources, especially if they got some misinformation there. So some scripts I kind of use, it's really, I normalize it. I say, hey, many people check online or use AI. Like, what have you plugged in so far? What did it say the main takeaway was? And so, hey, let's see what that says to what your lab's actually show and how I would interpret it. But really the goal is to invite patients to sort of share this with you and not to scold them. Because at the end of the day, what you really don't want to happen is that they don't tell you that they're using it because almost all will use it, whether they want to or not. Like I said, because you can't even Google something nowadays without having an AI response come back to you for the most part. So there is this sort of 2x2 table listed here that sort of talks a little bit about privacy and confabulation. So it's really important that we understand the concept of data memorization and leakage risks when uploading identifiable health info to AI tools. LLMs will occasionally invent details when unsure, and that's a known risk. And so it's important to have patients stick to vetted sort of portals, patient portals, or other resources to share questions with the clinic instead of pasting the reports online. And so this 2x2 sort of goes through a little bit of that. So there's a low privacy risk, not a real risk of problems if patients are posting things to the portal. The top right shows low accuracy risk and high privacy risk when people are pasting things directly into AI. And there's a low privacy risk and high accuracy risk when people are just looking for general health information and not their own personal information there. And if it is sort of a general-ish question, you can have some amount of good information to come back. And then there's a high privacy risk and high accuracy risk when people are sort of using forum data and other sort of posts and having identifying information there. Okay, so sort of getting into some specific scenarios in addition to the ones that we already have. So I'm going to go into these scenarios and talk a little bit about some of the common landmines that come and ways to actually maybe get around them. So, for example, a variant of uncertain significance in an immune dysregulation gene. Poor assessment would be if the patient leaves thinking that a VUS mandates treatment. They use it with a sort of positive language when describing it to the family, or they plan to start alternative supplements just in case. So, a script to kind of interrogate this would be, hey, if a cousin asks whether this is bad, what are you going to say? But what we'd really be shooting for here is the patient's ability to explain uncertainty accurately. It might mean something, but we don't know yet. We're going to kind of sit tight and look for a reclassification with time. Stated surveillance, cadence, and who else would maybe need testing. And in this case, it would likely be nobody. And can answer, if a cousin asks whether this is bad, what would you say? They can really give you an accurate answer there. And I often think that dealing with a poor assessment of a VUS, your pretest counseling can really go a long way in identifying where a patient is going to fall, whether they are just sort of grasping for answers or just doing a test because, hey, I want to see if there is a risk here. So that pretest counseling can be really, really helpful in patient cases and getting a sense of where a patient's going to fall in a situation like this. So, for example, we'll do another case that has to do with HLH predisposition. So let's say that somebody has actually done a genetic test and has identified that they have a genetic condition that predisposes them to HLH. A poor assessment example would be if a patient thinks that just because they have a mutation, this means they have a certain recurrence. I think it's important that penetrance is discussed, or in situations like this, if they were done and it was a negative test, that they're kind of, oh, so my test was negative. I'm totally out of the woods. If they're not able to rehearse an emergency plan or raise appropriate concern when they have a fever and ask for evaluations, that can also suggest poor assessment. An effective assessment would be if a patient is able to restate what they do if they have a fever or what's the emergency plan, if they can actually discuss what the next steps are with their caregivers and have a good understanding of like when to be concerned and when not to be concerned. And so asking a patient, hey, if you have a fever of 101 tonight, what are you gonna do? And that can really help with getting to an effective assessment in these situations. So in a patient with bone marrow that has a genetic test that's negative, poor assessment would basically believe that, hey, like I had the negative genetic test, like I'm good. And as a result of that, has some sort of lapses in their surveillance or disengages from follow-up after hearing the test is negative. Kind of like I alluded to before, just because a panel was negative doesn't mean that if we did that same test 10 years from now, we wouldn't be able to identify the cause. And so giving patients an understanding of when to follow up is really, really important in situations like that. So effective assessment in this situation could be a patient's ability to explain their residual risk and ongoing surveillance rationale. They're able to state what labs they're going to be having in the future and what symptoms would trigger a reevaluation. And if you can ask them about different scenarios and it can sort of tell you under what situations they should be all good. And this is often something that their hematologist could go through with them. And if they can actually repeat that back, that sort of suggests effective assessment. Patients with chronic immune cytopenias, I see a number of these in my adult genetics clinic. And in situations like this, poor assessment could suggest things where patients are chasing every portal lab update and flooding the portal or triage with their concerns. They can't really distinguish just sort of the watch and wait versus the call now situations and really have no clear thresholds understood that all really results in really increased anxiety. Effective assessment, though, is really exhibited when a patient can outline, what's the sort of agreed upon platelet or ANC thresholds that I should be thinking about? What's sort of the self-monitoring steps and when should I contact you? And then a sort of written action plan for those individuals who are calling quite a bit to say, hey, these are the situations where I'm calling and these are the situations where I'm not. And making sure that your on-call team is aware of all of those things is also really important when it comes to sort of system aspects of things. And a script you could sort of use is, hey, so if your platelets just come back at this, what would you actually do next? That can really, from a pre-test counseling standpoint, help you on the back end. Like I said, they come to you to clinic, you're repeating labs, and just reiterating, hey, let's go through that sort of script again. That's always really, really helpful. One that we sort of see semi-regularly now are incidental findings on exome. An evidence of poor assessment is obviously a sort of complete dismissal as being irrelevant because that's not why they had the test. Not really understanding what the referral plan is. If you have a patient who you do an exome for because they have intellectual disability and seizures, but they're identified to have an inherited cardiomyopathy related condition, just because they see a neurologist and a primary care doctor, that doesn't mean that they shouldn't be seeing a cardiologist now that this was identified. Also, with this, a lot of these things rely on other family members potentially at risk, and them not understanding that is also evidence of poor assessment. Whether they choose to let them know or not is up to them, but I think we really want them to understand that the communication around this is important. Evidence of effective assessment would be them understanding the referral plan. So who are you going to see? I'm going to see cardiology now or in the cardiomyopathy genetics clinic. Understanding how they could communicate with their family and insurance steps that are a part of that. And then they could sort of teach back how you are going to be managing this incidental finding or secondary finding and not ignoring it. So how do you implement this and document this in the actual real world? So clinics are incredibly busy. I mean, I'm kind of preaching to the choir here, but pre-visit, it'll sound like it's a really official thing. That's why I put it in quotes. Often, Bridget, the genetic counselor I work with the most, and I like before a clinic will just sort of say, oof, I think this one, hey, it's going to take a little bit more time. Let's build some time into our schedule to talk about them ahead of time. So these things can really flag high risk encounters and sort of come up with a game plan of how are you going to run that visit, how that's going to work. I often find that the MAs who are rooming patients can also give me a big sense of how it's going to be in that room. An MA you work with quite a bit can really sort of read the room like, hey, this patient is super anxious in there. Oof, vitals did not go well. Their blood pressure's through the roof. And that can give you a sense of what to expect when you go in there. And then if you do have checklists, you can embed them into templates so that it's really easy to document these things in there. And so these are all of those things sort of I use to actually plan a clinic to fit in this really important aspect of what we do. Medicine's a team sport now. Nurses, APPs can really help with reinforcing some of these teach back summaries and follow-up messages for patients because like I said, it's sometimes hard for all patients to get all of the information from visit one. And also you can just sort of telehealth visits can be used just quick check-ins, whether that's actual or virtual visit or a phone call. And then I keep harping on documentation of this, making sure that you're documenting who's struggling with understanding this information and how are they dealing with it and what are some of the strategies used, what was successful, what wasn't, can really help the entire team going forward. Some sort of quick tools that are out there in this space as well. So there's an AHRQ action plan form. I actually think that this is patients can use this Ask Me 3. So the three questions, I really like this. It's a patient who basically can ask a provider, what is my main problem? What do I need to do? And why is it important for me to do this? And I think that really conveys a lot of what we're trying to do here. And I think it's something that can help a patient get out of the kind of like, oh my gosh, what do I ask? What do I ask? What do I ask? And it can help them boil down to like, wait, what do I need to get out of this visit today? And as mentioned, I already talked a little bit about interpreters, but I usually think that our interpreters are just so beneficial in these situations because it really does slow me down. And it's just another voice in the room who, especially if you have an experienced interpreter, can really help read the room a bit. I really think they're super valuable in situations like this. Mentioned already before, I'll mention it again. Documenting this is really, really important. And nowadays, most, if not all, portal visits are recorded in the electronic medical record. And this really does protect clinicians and informs colleagues who sees the patients next. For in biochemical genetics, we have a number of patients who I see on the outpatient side, but I'm not always staffing the inpatient side. So when a patient then is admitted, it's really important for them to be able to sort of see what's been documented, how we're going about some of these things, and it does help them do their job better. So sort of some sample wording is put there for how these things can be put into notes, and it's super simple. It's not that difficult, but does really benefit all of us from a medical legal standpoint. But then also, given the team-based aspect of medicine, it helps our other team members with things as well. I did mention this already before. So this is a really important aspect of what we do, but often many disputes, when there is an issue, hinge on whether comprehension was verified. So documenting this is incredibly important. And again, if you have follow-up messaging, making sure that's documented as well. Like I said, if it's portal, this is often automatically there. And so making sure that you're documenting assessment of comprehension is really, really important in all the strategies that you used. Some electronic medical record systems now, you can't close a visit unless you're actually saying that a patient understood what was conveyed or not. And while it's really easy to click that button, it is just highlighting the importance of documenting patient comprehension of the results that we're actually providing them. So just like a real quick 3 questions that kind of mirror some of those questions that a patient could ask is kind of bringing it home and summarizing it. What does this result mean to you? So this identifies factual errors, view as misinterpretation and residual risk misunderstanding. And what are you going to do differently because of it? This confirms their intent from a behavioral standpoint. Oh, I'm going to do like A, B, and C. I'm now doing colonoscopies once a year or something else. And what are you going to tell your family or the next clinician? So you're seeing me as a specialist, but when you go meet with your primary care doctor next month, what are you going to tell them about this visit? Sure, they're going to have my note, but what's your interpretation of it? And again, it's just another way to get to the bottom of all of this. So a quick sort of summary for all of this. It's really important to integrate comprehension checks into every result workflow. And you can do it this week. It's doable. Take what we've done here and share the toolkit with other leaders in your institution. So terminology and how we do things is aligned. And then, if it's possible, you could just sort of track one metric to see your impact over the next quarter and how this works. But like I said, a lot of us who have done this for a long time do a lot of this automatically. So it's easy to sort of think about it, probably harder to document. But sometimes it is for the individuals who are thinking about it more deliberately, it's easier to have it front and center and then to document it. So we all have our crosses to bear, but I really appreciate you taking the time to listen to this. And I hope that hopefully it was a good complement to all of the other great information you've gotten from the other speakers today. So thanks so much. I put some like references here from the stuff that I went through, but looking forward to chatting and seeing if you have any other questions at the next session. Thanks.
Hello, everybody, and thank you so much again for joining our nicer education camp this morning. I really found all 3 discussions really valuable, so I hope you did too. Just a reminder to post any questions that might come up as we are within this live Q&A session into the Q&A box below at the bottom of your Zoom screen. And with that, we'll kick off the live Q&A. And so I think we had one from the first session. The question was, can you address the phrase that autosomal recessive only affects reproductive risk statement further? The person asking the question provided further explanation. They have found heterozygous RAG variants that have reduced RAG activity and immune implications despite being heterozygous. Wondering if the thinking is evolving or more nuanced than that. So I think, thank you for joining Dr. Peng and then Kristin as well. So maybe if either of you, maybe Kristin or Dr. Peng want to answer that.
So I think that's actually multiple questions in the same question. So I want to break it down for the person who's asking the question a little bit. So yes, the current understanding of at least RAG1 and 2 deficiency is that you can have an entire spectrum of autosomal recessive loss of function mechanism of disease from nullomorphic to hypomorphic. I think that's a different assertion from saying individual variants themselves cause loss of function. Of course, we would expect or hope that each of the variants that contributes to the biallelic combination does cause loss of function. But the question of what is the loss of function threshold required to lead to clinical disease, I think, is a really interesting question. And I think maybe that's what the person is getting at. And the wonderful thing about genetically driven immune disease is we're constantly revising our understanding of exactly how these particular variants may lead to disease. So a really good example is FMF. Familial Mediterranean fever for a very long time was classified as only a sort of autosomal recessive loss of function condition. You had to have 2 identified biallelic variants, but now we have plenty of people who only have 1 who clearly have the biochemical and clinical phenotypes that we associate with FMF. And there's always sort of the outstanding question of how many of those people may have an undetected variant in trans, which probably will be better served by technologies like long read in the future. But I think that's a really good example of a particular paradigm where we've evolved evolved to accept additional inheritance mechanisms of disease. Another really good example is familial HLH. So for a long time, people really felt that STXBP2 related primary HLH had to be autosomal recessive loss of function. But now we're actually finding more and more people where we can only detect one heterozygous variant, where you do have, reduced CD107 mobilization and some of the, the biochemical and immunophenotypes of the actual defect, even if they might not have the full-blown clinical picture. And I think, as there, Angelo has sort of shown really in a lovely manner at his ESID talk, and as Dushan has shown through his studies of the potential for random monoallelic expression, there's probably a number of mechanisms above the level of genotype that could lead potentially heterozygous variant in a condition we consider to be sort of mandatorily, biallelic mechanism of a disease to have manifestations in people where we only find one particular disease-causing variant. So I think that's an open question that requires a lot more investigation. I hope that makes sense.
Yeah, thank you so much. They also had a follow-up question, and I think this one will be for you, Kristin. Just noting it would be useful to learn how to provide a stepwise information to teens if they want it that way, like, what could be presented at the first visit versus the second and third visits. Do you have any techniques that you use?
Yeah, I mean, it's ideal when you get that many visits with a teenager. And so when I do have the opportunity to do that, I think I try to just add one layer at a time with each visit to the complexity that we're talking. So if I'm seeing a 12-year-old at the start, the first visit might just be, what is it that we're dealing with? Like we found something that explains why you've had the symptoms that you had. And the good news is that helps us to take care of you. And then the next time we might talk more about the genetic piece of it, like it's in a gene, and a gene is an instruction that helps your body understand what to do. And we kind of work through that. And then third visit might be, now what does this mean for you more long term? Now they're an older teenager. They might be thinking about, what does this mean when I go to college, when I'm thinking about having a family? And so then we start to get more into the nuance of, now, this means that you are going to have to see whatever the doctor may be, your hematologist, regularly wherever you go for your life. This gene change isn't going to go away. When you're thinking about having kids, what's the language around talking to your partner about having this and getting them tested? Because they may not know that they are a carrier for this, if it's recessive or if it's dominant. They may want to help make decisions about whether or not you're passing on this condition to your children. That's, towards the end of those visits, when they're 16, 17, 18, I talk more about reproductive technologies, ways to not pass it on. That's overwhelming at a first visit when you're looking at like a 12-year-old, but certainly as we're kind of adding layers of understanding on over time, and kids' understanding is maturing over time, they're more able to start to process what these things mean for their life, because they've had that foundation and we've been talking about it throughout their visits, instead of having it be a drinking from the fire hose all at once, high pressure situation when they're first diagnosed.
Great, thanks. We also have a point of interest comment from the Schwachman-Diamond Alliance. They note that in a recent poll that their group did, patients confirmed that the most important need that they had at the time of a genetic diagnosis was to connect with another family and see what life after diagnosis looked like. So to broaden on that and turn it into a question for you folks, what have you found are effective ways to help patients identify these groups? To what extent are there resources that we as providers are able to find when our provider facing versus just the random Facebook group that you find online for rare disease? How are you approaching connecting families together?
I think it's really important to emphasize for the families that actually there's almost a nested matryoshka doll of opportunities, especially when you're dealing with rare disease. The community doesn't have to be just the other patients with that disease. And so for a lot of our patients who have, for example, a specific, genome instability syndrome, there's a lot of other groups, that have genome instability. So it's there's a number of different kinds of groups to become involved with beyond even just the immediate rare disease community for that specific disease. And I've definitely introduced parents who are very interested in advocacy and interested in participating in foundations or even forming their own sort of foundations to, other parents who've managed to do that in advance for their particular specific kind of disease. And I think that exchange has been really, really valuable. They've really shared a lot of sort of diverse perspectives with each other and sort of together helped advance the cause of, awareness of rare disease in general.
Hey everyone, I'll chime in. So I think the connection with the other families is obviously like really, really valuable. I think it's really important. I think a lot of times when a family does make that request, a lot of times, let's say I have a patient with newly diagnosed OTC deficiency and they're wanting to talk to another family. I think it's important to like know the other families that you're connecting with and where they're actually at and like their processing of their diagnosis. Because I mean, just being pretty frank, I mean, some patients are responding really, really well, or some patients are maybe struggling with the diagnosis more themselves. And so just because you're connecting two families doesn't always mean it'll be the best relationship. So the better you know the families that you're discussing, I think the better able you are going to be to do a little bit of matchmaking to say, what is this family really looking for with this connection? And is there a family that can really sort of provide them with that information? Or is it just going to be two families just bouncing off each other and it may just kind of ultimately not be the most beneficial interaction? And I mean, that's when you're sort of doing a little bit of hand holding when making those introductions. But I think just knowing the families, where they're each at, and is it going to be a really, as best as you can tell, a useful interaction for both of them, I think is something pretty important when I have those conversations.
If you have a great resource, whether it's like a patient advocacy group or whatever it is that you've shared with a patient, and you have other colleagues at your institution, share it with your colleagues, because it's always interesting when I see two families who are seen by different providers, and one will say like, well, I talked to this other family on Facebook and their doctor told me about this group and my doctor didn't tell me that. So I think the more you can share the wealth and make sure that everybody on your team is aware of these resources and consistently sharing them with families and getting them connected to these groups, the better for just the patient experience.
Thank you. Yeah, I was just going to ask a different question. So I am a general hematologist and a hemostasis doctor. So I, not frequently, but I do send genetic panels at times, some as broad as the cytopenia panel that Dr. Peng was talking about, and some very limited, looking for dysfibrinogenemia and such. But my question is, when we get these variants of unknown significant results, if there isn't, pathogenic finding, I do my best to do, pre-genetic test counseling. And I'm so happy to have been part of this today because I learned a lot about ways I can improve that. But, does everyone that has multiple variants of unknown significance or even one warrant a formal genetic referral? I do my best, to interpret them reading through the full report. And I think families don't really seek out formal genetic tests or formal genetic referrals. I think they kind of, default to what I think. And sometimes I don't know. Yeah, I don't know. I know we're ordering a lot more of these tests and there's only so many genetic counselors and geneticists. So just wondering your thoughts on that.
Yeah, I mean, I think one of the issues with our particular field is that most clinically trained geneticists and genetic counselors don't actually deal with genetically driven blood or immune disease very much in their actual repertoire of diseases. And so everyone is starting from some kind of from in some ways everyone's sort of starting on the same page, right? So the geneticists and the genetic counselors certainly would have more basic training in general understanding of genetics lingo and genetic principles, but they may not understand some of the nuances of genetically driven immune disease specific paradigms. And that often becomes a pitfall as well, because I've certainly had people who are much more senior geneticists than I, who I respect immensely, give the wrong counseling about an immune disease variant simply because it's not a disease that they spend a lot of time thinking about. And so I think this is where communication and collaboration becomes so important, because the immunohem room providers are going to be very valuable in helping suggest potentially further cell-based or other kinds of functional studies that might be what helps push that US over the edge. Maybe not from an ACMG perspective, but maybe from a management, like a true clinical perspective, right? And, like you might see for example, a inflammasomeopathy VUS and know, oh, I can send this FIN-PC assay to Roshni Abraham at Nationwide, but the geneticist may have no idea what that means, and then you can prove that there is hyper IL-1 beta and IL-18 secretion and really get your patient to that IL-1 blockade therapeutic regimen, and then the geneticist can take the information you've generated and try to help you get that VUS upgraded with the genetic testing lab by giving them that feedback. So it's really a collaborative effort, I think, from multiple communities in these cases. And I think that kind of, trying to learn each other's perspective and sort of what the language means for both sides is really, really important.
Yeah, I would agree. And I would just add on, I mean, I think we've reached a point where it's not realistic to think that a genetic counselor or a geneticist is going to order every genetic test. I mean, like equity and access to testing alone depend on non-genetics providers ordering this testing. And there's certainly not a responsibility to be able to interpret every VUS. But there is a responsibility to have some genetic literacy, right? To do the due diligence, to look into the variants. I think in the example I give during the presentation about the patient who had multiple VUSs that were all gains on the same gene. I mean, using some context clues and knowing who to reach out to if you don't know the answer, but you think there's a reason to be suspicious is really important. And having that transparency with your patients too, I would argue is important to be able to say, we don't actually know what this means right now for your health, but we're going to look into it and we're going to continue to assess it over time. And when you come back next year, I'm going to look into it again and see if the evidence has changed at all, because they can see those reports like we talked about today. They're going to see the actual full report. So we're not at a place where you can just say it was negative and ignore the VUSs. They're going to want to know often what those mean. And so being able to have that conversation with families in an honest way and say, there's some stuff we're still working on figuring out. Some of this, we don't know if it might be contributing. It might not explain all of your symptoms, but maybe it's contributing to something. And we're going to continue to learn together as we move forward. Can be really helpful for families.
And so this is a question for Shane. I was hoping to get a little bit more insight into the conversations that you're having with patients about their use of large language models and interpreting their health. I mean, I think that we as providers know that everybody's Googling, everybody's using ChatGPT to understand their health and the results. And there are some legitimate uses of these tools and probably could further understanding to a large extent, but how do you toe the line of, yes, this might be a useful tool, but here is where you should stop listening and talk to me?
Yeah, this is a great question. And I let me also just preface this with anything related to AI and LLMs that I say on April 8th, 2026 is probably going to be out of date on April 12th, 2026. So it's this is kind of how we're dealing with it right now. And I think first principles is at the end of the day, just undergrads writing essays, this is being used in our, just putting our head in the sand isn't actually probably useful. I mean, at the end of the day, people are using this and they're going to use it whether we tell them or not to. And this may be a little, not to say it's kind of your parents, you can do whatever you want, but I want you to do it in the house kind of thing. And that's kind of how I look at this tool in some ways. And so, I mean, ultimately, I think the thing at the end of the day, I just don't want to lose is the therapeutic relationship I have with patients. And so every patient is going to be a little bit different. And I ultimately am fine with a patient doing, I don't say whatever they want, but I mean, largely I trust a patient's judgment as long as they're letting me know what they're doing, whether that's a patient not taking a medication. And it's fine if you don't take a medication, just don't tell me you're not taking medication because I don't want to adjust the medication thinking you're not taking it. And it's the same thing with LLMs. I mean, ultimately, I just want to know that patients are using it and that's fine. And then they can come to me with that information. I mean, ultimately, the sort of guardrails that I would outline is hey, if you are going to be making medication changes, if you're going to be making recommendations to other family members about testing and if they should have testing or not, I would say you should be talking to me first. So if they are really just going to this from an informational standpoint and, just using this to help them process the information, I think that's great. But I think when it gets down to actual medical decisions and this information kind of getting beyond them and affecting others around them, I think having my input would be valuable. So yeah, I mean, it's really tricky and it's nuanced, and I'm avoiding saying, well, it kind of depends, but I think there is a lot of that in this situation. But yeah, that's how I would go about it.
As more and more people are ordering genetic testing who may not be genetic counselors or geneticists, today's resource is something I think I'm going to share with people on how to, go about the pretest genetic counseling. Are there any other curriculums that you know of or resources that you all use to share with other people who might be talking to families about, genetic testing or what the outcomes might be?
I know there are a couple resources online. Like I know Nemours puts one out that's like a non-genetics provider training on interpreting genetic testing and counseling and things like that. That's really good. NSGC, the National Society for Genetic Counselors, has some resources on their website as well for counseling topics, specific diseases, resource groups like patient resource groups. So that can be really helpful as well. I'm not sure, Dr. Peng, if you're aware of anything else.
Yeah, I mean, to be honest, I find resources less great than just direct communication in most instances, just because people have such a wide range of reasons to be confused about genetic testing. And I think that resources that you suggested are great. I think NSGC makes really, really nice patient-facing resources in general. In some ways, a lot of the sort of guidance that I'm providing for patients is almost trying to clarify more with their providers' understanding so that their other providers can be on the same page about communicating what some of the genetics means, or what genetic testing even means, or what screening versus diagnosis means, because it's more than just what I say that matters. It's sort of building an echo chamber with the same conceptual framework.
Yeah, thank you. I think we all work with trainees, and so teaching fellows how to maybe have these conversations with families too.
I have a somewhat self-indulgent question for Xiao, which is as you're moving forward in some of the newer generation testing types, how often are you using somatic panels like the Mashion panel, which NICER helped develop, in testing your patients? What sort of indications are you using that for? And have you sent this panel and had any actionable results? We've sent it a couple of times here at Michigan and we're using it more, but not much has come up for us just yet.
I think there's a simple answer to your question, Mark, which is I think we all have to face the reality that what we consider to be the ideal assay for a particular hypothesis may be limited by situational things like institutional and bureaucratic and financial logistics. So I think one of the main barriers to the use of really nice assays, whether it's optical genome mapping or somatic IEI panels or what have you, really comes down to whether or not our patients are able to, we can get insurance reimbursement for those tests. And this is why it's often really important to work with the assay developers to try to help them figure out how this might be possible, because if they can't be reimbursed and stay in business to continue to offer these tests, then it makes it really difficult for us to be able to use them. But I think that's maybe been the biggest issue with our institution and also with others. But if there's, specific somatic variants, it's a little bit easier. So, it's easy to get single, UBA1 testing or single FAST testing. And I think there's a little bit more acceptance in general of the panel that has been in existence longer, the Wustel panel. And as the gene content of those panels expand, I think, that's where the challenges really arise, fortunately. But as Megan Cooper would say, if you did an exome on your patient anyway, you might as well first look at the exome.
Always a fair point. Thanks for joining us today for this education camp. The next one will be happening June 10th. It's a Wednesday for a session on atypical spleens. You can find more information on our website, nicerconsortium.org, and you can also find previous recordings on our NICER YouTube page. Until then, panelists, thank you for joining us. Thank you for your talks, and thank you everybody that came for your attention and questions.